Yes. Okay. Dementia and social isolation is Anna Pihlqvist from Helsingborg municipality and Gustaf Cavalli from Masterclass, Sweden. Welcome. I give the word to you.
Thank you.
Thanks.
Okay. So we want to start with a short story from Maria, if we have sound. I don't know if we have it working. I can tell you the story instead. This is Maria and her father Bertil. It's 30 years ago. Bertil was diagnosed with Alzheimer's disease. And it's the beginning of the story of the two services that we're going to tell you about today. The needs Maria felt was to connect with others in the same situation, to get information, and also to sometimes have someone to talk to within the municipality without having to tell her story again and again and again to new people. So with that said.
So Maria was very young when her father turned ill, and she lived in a very unique situation. So she was lonely in this situation. For an older person, loneliness is different. We've heard a lot about it today. Oftentimes, when you're older, you've lost contact with earlier friends. You pass on. Some of your friends and family have passed on. Your social network is often getting smaller. And like Bengt said in the beginning, 40% of people 75 years up don't participate in social activities. And they don't have a job, so they don't have these social contexts where they can get new acquaintances. So it's a different kind of loneliness.
Mm-hmm. So 11 years ago, Maria and I set out on a mission to bridge the gap between healthcare, the municipalities, and the carers in Sweden. We created a web platform called En bra plats, which translates to a good place. And what we wanted to do was, just as Anders said before, it's not about things, it's about people. So we started looking at how could you provide, how could you make it easier for carers to cope with their situation. And we looked to the research, and it says if you could provide them with information, knowledge, and a social network, it's proven that it eases their situation. We added to that the need that Maria had felt, and to have a contact person within the municipality. Today, 10 years later, you can find our service in 20 different municipalities, and they're all connected in one platform. I can also say we don't just work with elderly or dementia that we're going to talk about later. We have over 180 different diagnoses, so we work with the whole spectrum of being a carer. One fundamental thing with our platform is that you as a carer can be anonymous. Sometimes you have the need not to be connected to the disease within friends. You need to be able to speak freely without people you think they might be judging you or so. So from day one we have built in a way to be anonymous without but at the same time being able to feel secure. And that is something that isn't that easy on the internet, because if you're totally anonymous, you can also pretend to be someone that you're not. So therefore we have built into our system that we know who the carer is, and we show other carers the age and the gender of all the users to prevent from trolling and grooming. So the social network works like this on En bra plats. You can connect with others on a one-on-one. Then you use the matchmaking function, so you can, just like a dating service would function, you can search for others that are in the same situation as you are. Then you can add each other and talk one-on-one. We also have groups where you can attend a specific group where we have different topics. We also have moderators who work within the groups, not just to keep track of what they say, but also to help them to keep on talking in the group. A lot of people like to read, but not as many like to write. So that's a little bit about the background. I can take an example. We had quite early when we started up, we had a group of 3 elderly. They were 75 plus. They lived in different places in Sweden, who connected through our platform, and then they started to talk to each other daily for a couple of years, actually. And they never told each other their real names, but they talked about everything, about life, about everyday life. And what they had in common was that they lived close to someone with a dementia disease. So they were kind of that hard getting out of their house or where they lived, but they had time. With that said.
So the last point here, professional support. Every user can choose a local support as a connection, so have a direct contact. So in Helsingborg they can choose me or a colleague to me. So they don't. It makes it easy to just write a message, and you can do it any time of the day, at night, and it makes it a bit easier. You don't have to explain, because that's one of the big obstacles to reach up and take contact, that you have to explain your story one more time, and it's quite emotional oftentimes, and it's quite a big obstacle. Here you can have an example. Just the other week, a man in his 70s wrote me a very short message, directly like a message to me, and he just wrote, "I feel so sad and blue sometimes." And I answered him then, and I answered him and asked if he had someone to talk to, and he just wrote me back, "I want someone to talk to." I think he's not very used to writing, but he could get this message at least, and I could take contact with him and tell him about groups we had locally where he could meet others in the same situation. So now he's going to start in one of these groups in October, and it's an easy way to, instead of having to tell the whole story, I already know a bit about his situation.
Yes, so 3 years ago we wanted to try to solve another problem that we have come to face during this time working with Bra Plats. As I said earlier, on Bra Plats we work with 180 different diagnoses, and we have a lot of information in there that they can find that suits you in your situation. But what we wanted to do was to pick out the carers that live close to someone with a dementia disease. And we wanted to become like an assistant that gives them the right information in the right time, that keeps track of every single individual and where they are, just their situation. So what we did was, together with Helsingborg, we started a project where we once again didn't start with a digital platform or so, but we did start with the needs. And we came up with that we wanted to somehow provide the carers with an automatic guide that follows the carer throughout. It could be up to 20 years. It can also be 5 years. Yeah. So what we did was that we started with looking at the journey that you go through when you are living close to someone with a dementia disease. We actually started with 4 journey points. It was in the beginning when you get the diagnosis. It was when you start to get help at home, because home care. When you move into elderly care, and when the person with dementia dies. But we soon found out that when we started to interact with dementia nurses, with other professionals that meet both the people with the disease and the carers, that there are a lot of more stops along the journey where you need to be able to get the right information. And another thing with this is that today we are overwhelmed with there is so much information. There's not a lack of information. The problem is that you have to try to get the right information. So therefore, we got, for example, from nurses that said, we have provided them with the information 3 times. We know that. But they say that I've never gotten the information. Yeah. So we think it's really important that you get just enough information to get you to the next point, not the whole story at once. Like if you want to go by car from here to Paris, you want to know how to turn and get out of the city, not how to turn in Germany or like that. Yeah. So with that said.
Mm-hmm. So when we started describing these different phases, we quite soon saw that we had one phase at point 13 here, that we were quite anonymous at describing that this is a point of loneliness. This is where your close one has moved into a special nursing care, or and you're home alone. And it's not just that you go home and have an empty bed if you're living together. It's also the loss of a role, being the caregiver that you've probably had for many years. And it's a big emptiness. It's a lot of what we've been talking about today, different kinds of loneliness. And it's also that you're left with a bad conscience. Maybe I could have done more. How could I send my loved one to this nursing home? Maybe I should have been able to do more. And also shame of these feelings and not have been able to do more. So you're left with existential loneliness as well. So many hard feelings. And these are very strong feelings that they're not easy to give you advice on. And it's hard to deal with at this point. So we need to get information earlier to help this. And the more we looked at it, we saw that there were plenty of points of loneliness during this and social isolation during this journey for a caregiver to someone with a dementia. For example, early on at point 5 here, this is quite soon after you get the diagnosis. A lot of people feel very alone in their situation, even though they, with their mind, know that we're not the only ones. You feel like you're the only one, and no one in your close, like friends and family, really understand what you're going through. They know that it's hard, but they don't really know in what way or what you're going through. So here it's I'm gonna describe here number 8 here, when the family member loses more and more of his or her abilities, you start taking a step back from social activities, and it gets harder to do things that you've done before. And gradually you lose contact with a few of your friends. And going on to point 10 there, when your loved one has extensive needs, and you really have to be there all the time. They're very dependent on you. You can talk a lot. You're going into a social isolation because it's hard to leave home, and it's also hard to do things on your own at home. Some caregivers I've had contact with said that they don't even get to go to the bathroom on their own because their loved one is so affected by the dementia that it sees that they get worried, and they don't really know where did my spouse go, or and it's not until they've gone to sleep that they have this time for themselves, and that's quite hard. And point 16, 13 we talked about, and point 16, where your loved one passes on. Of course, it's a very obvious loneliness. So looking more specifically, what we do in Demenslotsen is that we give specific advice on this situation. What can you do? What kind of help can I look for to make this situation a bit easier? So in point 5, for example, we want to help the caregiver see that they're not alone. And locally, for example, we have information about self-help groups that we start. We have a group starting now that's a self-help group for the person that's a caregiver, and a parallel group for the person with the dementia diagnosis in an early stage, because then you can still participate and see what's happening to a certain extent. And information about why should I identify as a caregiver, because that's not normal to set a name on yourself, like you're a relative, you're a husband or you're a wife. You don't really label yourself, and that. But by labeling yourself, it's easier to look for the right help from society or so. Another example at point 8. We have information that this is where you get to a point where you stop joining social activities, because it's getting a bit hard. But this is so important to keep up these social contacts. So here's advice on on activities that you can start doing together that are maybe new for both of you. So you're not on different levels, but you're new, like painting or different examples. And also tips for communicating. How can I communicate so that it works? And what tips can I give to my friends and family so that they know how to communicate in a good way? Information about technology, alarms that can help, that you can leave home and not feel worried that my husband or wife is going to leave home without me knowing, for example. So with this kind of tips, you can keep on the social contacts that you have. And these different tips are either local or they're on a national level. So I put in the information that's relative to Helsingborg, our municipality, and then the company puts in the information that's on a national level.
So we want to share some of our experience with working with both these services, and maybe the first one not to forget is to keep it simple. We work with both the professionals that work within the municipality and in the healthcare sector. They have already a lot of different tasks before we come and give them another one. So it really has to be easy to work with. The same thing goes to the carers. We can't educate the carers in how to use our services, because we want to be able to provide this to a lot of people. So therefore, it has to be simple. Next point is finding new ways to work with digital services. During the 10 years we've been working with municipalities and the healthcare sector, we really need them to be the ones who inform the carers in an early stage that they can get support by our platform. So how do we do that then? Our last take on this is to create something we call the Digilog way of working. We have a digital service, but out in the workforces that meet the carers, they use analog paper with a specific code on it. So every carer gets one of these, and then they can activate their account with a code. And what's good with that is that we can then track where does this work? Who activates a lot of carers, and then we can ask them, how did you do? And we can then pass it on to others to help each other to reach out to more carers. It's also a feeling that, for example, if you just have met a couple where you've told the wife and the husband that you have Alzheimer's disease, I mean, it can be a really tough meeting for the professional as well. And in this case, you have something of value to give to the carer. It's also kind of a good feeling. So we try to kind of make a win-win. With that said,
yeah, another side of that is that it's so important that this is like charged, that this is a human touch giving, a human hand giving this to the person, because otherwise it's just information among other information. As we really need a person that tells you, looks you in the eye and says, I've heard your situation and I think this is what's going to help you. Otherwise it's just information. And this is one of the most important processes that we have right now. We have a system that's good, but we need to tell people about it and
to reach out.
Reach out.
Then it's a work in progress. It's never going to be a finished product. I mean, researchers come up with new stuff all the time. We have to be agile in picking that up and putting that in the right place along the journey. So it's never a finished product. And we have also built in a function in the Menstruation that can collect the carer's needs. So, for example, if you are at, say, journey point 13, and you go through the information, and then you feel like, oh, but what about this then? They kind of feel a lack of some kind of information. Then they can connect to us. They can leave their, this is my need in this particular situation. The good thing about that is, normally in Sweden we have something called like an idea box. You know, you can put ideas in a box. Huh? The problem is you don't get the whole picture. You get like, this is a need I have, but you don't know where along the journey that need occurs. So we actually get not just the need that they leave, but we also get where did they, where were they along the journey? On what point were they when they left that need? So you easily can adjust that information.
Yeah, I think that's all
we said. Everything.
Yeah, pretty fast.
Yeah. So, yeah. Thank you so much for listening. Thank you.